وبمشيئة الله تعالى فإن هذا الربط الفضائي سيمكن الأطباء المعالجون في مستشفى الملك من مناقشة حالة المرضى مع زملائهم في المستشفى التخصصي في الرياض عبر الاتصال الفضائي.
تهدف عملية الربط إلى تقديم الخدمات الاستشارية الصحية عن بعد لمرضى العناية المركزة متى ما داعت الحاجة.
الله يحييك دكتور، كيف اخبارك؟ الحمد لله.
A young Saudi guy with 30 years of age.
I already told the story.
Okay, you have told him. Okay, so we'll go straight to the Faisal. Can you see the image there?
Yes, I can see it.
So the status quo remains over the last 14 days as it is, in spite of skull traction of weight, and the guy has a bilateral diaphragmatic weakness. He could not be weaned off in spite of repeated attempts at weaning, and otherwise mentally he is very sound. He is fully conscious, very alert, stable hemodynamically, and repeat films, follow-up films after this skull traction repeatedly show no improvement. So in conclusion, we are thinking that there is locked facets of cervical 5 and cervical 6. Just wondering as to what else can be offered in your center for this young Saudi guy. Dr. Jibali is in charge of this case. He is a consultant neurosurgeon. He would like to give you answers to any query you might be having regarding this case.
So he presented with bilateral locked facets, C5
and C6.
5-6.
C6 bilateral and complete cord injury.
Yeah.
Yes.
That
Complete
for the last 14 days.
Yeah.
And he was on traction
Yes.
for 2 weeks.
Yeah.
Yes.
And there's no reduction.
No reduction.
Yeah. So I don't see the cord here. Can you move the MRI inside the front cup?
Okay.
Put the X-ray.
No, let me can show you. Can show you.
You can see now, doctor?
Yeah. Please, can you move on? More? Yeah, okay, that's fine. Stop there. Okay, and you cannot wean him off the ventilator.
Yes. Yes. Today we discussed with Dr. Jamil. We will try some maneuvers. We will try to put him on minimal pressure support, and that time we will take an X-ray so as to assess the placement of diaphragms.
Yeah, okay. And when he came to you from the hospital, he was completely paralyzed.
Oh yes, from day one. Yes.
Was spinal
From day one. Yeah. Okay. So
was complete quadriplegia. Was spinal shock.
So the thing that this MRI was done recent.
No, this is done on day one within hours. We did first CT and then we arranged within hours for MRI.
Was the day of admission? The day of admission is MRI. Okay. Like 10 days ago for
But we do serial blood X-rays, lateral view, because he is on traction now, and not reduced.
So there is no disruption, there is no reduction at all.
Yeah.
So in this situation, so he has obviously he has complete cord injury, and if we do something, we do it just for mechanical, just for internal reduction and fixation, and with bilateral facet. Usually we go posterior, reduce it, then we go anterior and fix, and take the disc and fix. The problem with this surgery, he will not probably would not get benefit. The only benefit that he will get is facilitating rehab. Like with this picture, you cannot keep him like this, because when you start rehabilitation in the future, he's gonna probably develop more cord injury and hematomyelgia, and this hematomyelgia can extend and go to the brainstem. So the only thing that can be done is, in this situation, is to repeat the MRI to rule out any extended hematomyelgia that can go through the cord and go up to the brainstem, and probably this is the cause of his diaphragmatic paralysis. So because it should reach the level higher up than this to cause diaphragmatic paralysis. So the plan is to repeat MRI, and after that he needs to be fixed, like internal fixation from posterior and anterior both. Because this is bilateral blood facet, it was not reduced by traction, and most likely it will not be reduced. So the best way is to go posterior, reduce it, then anterior, take the disc and fuse it. But this cannot be done in your institution, correct?
Dr. Jibali will answer that thing. Can it be done here?
No, يعني the problem now, he is under skull traction now, and we can't do MRI. This first. يعني with skull traction, we can't do MRI now. Second, facility for posterior and then anterior is not present in our hospital now. Surgery for this case is not available now.
Yeah, but the skull traction, my understanding, was not doing anything.
Yeah,
Was not.
yeah, that is our question.
So your
That if it is not doing anything, why not to remove it?
Yeah, please,
Yeah,
in these cases, I'll tell you, the scenario in these cases usually goes when they come to the emergency room, immediately CT scan, MRI, and after that you put them on traction just to hold them. After that you take them to the ward and you fix it. Early fixation is preferred than delayed fixation. This is the usual scenario. But you see this patient late, patient completely paralyzed, he was put in traction. For a long time, there is no benefit. You can remove the traction, do MRI. Okay, put on color, do MRI. Then after that, according to the MRI picture, we can go anterior or posterior, but most of the time we go posterior.
also 2 days before done tracheostomy was done for this patient.
Yeah, so
After this long time, they decided to do tracheostomy, and this done 2 days before. This will affect in surgery or something like that?
Well, tracheostomy, no, it can be done even with tracheostomy, the procedure. But this is a very good question. But it can be done. The procedure itself, even from anterior, it can be done. So the tracheostomy, I guess it was open.
Yeah, open tracheostomy. Yeah.
In the OR, yeah.
It was done bedside because he could not be moved with ease to the OR because his traction and all.
Yeah, exactly. The ultimate thing is just to do, the fixation is just only mechanical. It will not improve his neurological state. This is the most important thing. Like, we are not aiming to improve his neurological state. He has diaphragmatic paralysis and he has complete for 14 days. And decompression at this stage will not improve his neurological state, but it can facilitate the rehab. So you cannot keep him in traction forever. You cannot leave him like this forever because he might have more microtrauma and hematomyelgia that can extend to the brainstem. And I think this should be ruled out since he was on traction for a long
Ask
time.
if this patient can't be weaned from ventilator and become dependent on ventilator. Any facility can be offered for this patient, because we have one patient before, 2 years before, he was upper cervical also fracture spine, and he can't wean from ventilator. He stay on dependent on ventilator long time. He was on Saudi, and he stay many months here in the hospital.
Yeah, Dr. Jamil saw that case when he came here.
Yeah, I already did discuss all this, that finding what to do about the ventilator with Dr. Aslam.
Yeah.
So I told him what things to test for the diaphragm, to make sure it's working, see what is dial volume, see what is NIF, and basically based on that, if all the above is negative like pressure, then probably you need a long-term ventilator And if they didn't work, the best bet for this guy, the early you can go home, the better, because you decrease the infection. You already have a pseudomonas from sputum, and as Dr. Odaibi mentioned, he needs to have a surgery as soon as possible to stabilize the spinal cord so you can start rehabilitation. Otherwise, you cannot keep him on traction forever. Now the plan is as follows: remove the traction, get an MRI, push for surgery, and next step is to start the rehabilitation center.
Thank you very much. Thank you for your time and your advice.
Thank you.
Okay. Yeah, we'll keep in touch. Maybe on Saturday I'll contact you to see what's going on.
Now probably there is no need to send the CD. We have already discussed with.
You want to see the CD more details for the all the X-ray, or I think we have the picture, right?
So this is the map.
No. This is only online.
No, if the are going to send.
Okay, then yeah. Okay, there is no need. Only if in case they accept it, then you have to send the MRI. But at this level, there is no need.
Okay. Thank you.
Okay.
Thank you.
We have enough. But let's follow up on Saturday together to see the follow-up MRI.
Okay.
And we'll see if there's anything we can do, we can try our best.
Okay.
Okay. Thank you very much.
Thank you.
Assalamu alaikum.
Assalamu alaikum.